Hi, my name is Dr. John Kennedy. I'm an orthopedic professor at NYU Langone in New York. We're going to be talking today and showing the new 2.0 NanoNeedle, and we're going to be looking at specifically in the ankle joint at the anteromedial impingement and anterolateral impingement. And today we're going to be going, how do we diagnose this, and also how do we fix it? So we're just inserting this Apollo SJ50, which is this new and improved radiofrequency ablation device. You can see already that there's a little suction on it, which is very helpful just to pull in the particular tissue that you're looking for. We're using the handheld device here, and we just do small little bursts, and you can see how effective this is. And the other thing is, when we remember the old device, you remember all those bubbles that you would get, and of course you don't see that here. So just short bursts in very short order, we've taken away most of that scar tissue there. And you don't have to be aggressive here at all. Just these short pulses clean up that scar tissue in no time. And then occasionally we'll need to go back in and use the shaver to clean up any of the necrotic tissue left afterwards. You can see how effective that is. So we have now moved our camera onto the lateral side, so we have good visualization over medially. You can see one of the things that I noticed really with this 2.0 upgrade is that anytime you have flaring of the light, the onboard sensor actually reduces that. So you don't get those flare-outs that you see in a traditional scope. So I think for many reasons, this 2.0 NanoNeedle is really a massive advancement by comparison to standard arthroscopy. So here on this particular patient, you can see that there is chondral irregularity. There's a large fibrous and bony impingement here, and of course this is very common in soccer players and runners. So this is true anteromedial impingement. It's a combination of both bone and soft tissue, and this is where nano is really exceptional for in-office procedures. And you can see right across over into the medial mal, and we're going to be resecting all of that while the patient is wide awake and being part of it. And one of the great things is when you do this and the patient is awake, as you're resecting this and you ask them to move, they get that tactile feedback. They feel that their joint is so much freer than it was before. So we used, again, the standard 3 or 3.5 shaver. And the first thing we're going to do is just, again, take away all of that soft tissue that we can see there. And fluid management is key here. The pump is typically at around 35 millimeters of mercury. You'll adjust that as you need to. But you can see that if we put too much suction on this, we can really pull in all the soft tissues. So that's not great. So as we're taking away this soft tissue, things to be aware of around here, we don't want to shave upwards. That's where all the name structures are. We want to keep away from that. So you can see that the cutting or the action part of this blade is always facing down, sweeping down the neck of the talus. And there's that exostosis that will be causing some impingement. We'll take that away. It's relatively small in this patient, but we'll be taking that away with both a shaver and a burr in one moment. So people always ask, how much soft tissue or how much bone do you resect? Well, the answer to that is on the tibial overhang, which is here, you really want to be getting that flush with the anterior aspect of the medial malleolus, which is here. So we're taking away all this soft tissue. And this will bring in the anterior border or the anterior fascicle of the deltoid, which is here. And again, as we know, the deltoid is a very, very strong, robust ligament. And I think we can afford to take some of those fibers away to prevent recurrence. So we're just now going to swap over to a burr. We've taken away all that soft tissue, and you can see that already there's less soft tissue impingement. And now we're going to go to a burr to actually remove part of this, almost do a plafondoplasty here. So this is this is what we would do normally in office. All of this is done with a patient wide awake and being aware of what's happening all the time. So with a burr, as we know, the technique for a burr is constant motion. We never keep the burr in one place for any period of time. You don't want any troughing to occur, but you're constantly moving it around and taking away millimeter by millimeter, that anterior medial aspect of the joint, keeping the horizon stable so that you can always see where the joint is, avoiding any iatrogenic injury to the cartilage underneath. So again, we're just constantly moving that back, looking to where our marker is, which is the anterior border of the medial mal. So constantly moving. And again, you can see as I'm doing this, there are milliseconds of flaring as the camera moves in and out. There will be flaring and some glare from the sheath of the burr, and then the sensor, onboard sensor, corrects that right away, so you get a constant picture. So we always take a little bit more than you would need on the basis that the body doesn't tolerate a dead space, so it will try to fill this in with some scar post-operatively, but if you take a little bit more bone, then the likelihood of that scar causing any pathology is very low. So then we move over onto the anterior border of the medial mal, and we'll take a little bit more bone from there. We don't have to be too aggressive on this. In this particular case, there's not a big overhang, but you can see the tibia now is in line with that anterior border. So that's enough resection on this. Oftentimes you can be here for quite some time taking this away, and then you can swap out to a 4.0 shaver if you need to be a little bit more aggressive, but that's pretty good. Now, one of the things that we all learn from our mistakes, and one of my fellows, when we were operating on a soccer player, told us, I thought the case was over, and he said, well, we should really look down here onto the neck, and down here there was a very large exostosis. So I've always remembered that case, that we always want to look onto the neck, and again, using the burr, being careful to shield the soft tissues away from the cutting blade, and again, constantly moving this around to avoid any troughing. This is typically where you will find a large exostosis on the medial neck, so always look for that. But again, you can see that anytime I move the camera in a little too close, so there's a flare or glare off that sheath, the onboard sensor immediately recognizes that and brings me back to a normal picture. The great thing about in-office needle arthroscopy is the patient is awake, and you can ask them now to move their ankle into a dorsiflex position, so you can truly see that there is no impingement there any longer, and more importantly, they feel that. And I think that's the buy-in from patients. We've published on this to show that patients really do like this procedure and that they understand what's going on, and then they can titrate their activities post-surgically based on what they've seen at the time in a realistic fashion. So I think it's very, very helpful in that way.